ensuring patient safety. Just like access to clean water and air have taken just like we have taken access to clean water and air for granted, we have taken antibiotics also for granted for too long. And while decades of overuse and misuse of antibiotics, we have accelerated the emergence and spread of resistant bacteria, access to antibiotics hence remains a major issue. To make the concept of antimicrobial stewardship more acceptable, the association between the AMS program and patient safety needs to be emphasized. Now, let me take this opportunity to introduce our esteemed speakers for the day. Dr. Dhanya Dharampalan is currently working as consultant in pediatric infectious diseases at Apollo Hospitals, Navi Mumbai. The topic for today's webinar is Antimicrobial Stewardship, Practical Tools for Ensuring Patient Safety. And our esteemed speakers are Dr. Dhanya Dharampalan, who is currently working as consultant in pediatric infectious diseases at Apollo Hospitals, Navi Mumbai. She is the national coordinator for the Apollo Antimicrobial Stewardship Program. She is also the co-lead for the Global Health Subcommittee of the Pediatric Infectious Disease Society, USA. Ma'am is also the member of the AMR Task Force for NAT Health. Ma'am, may I request you to kindly start with the presentation?
Thank you, Ms. Pritindra, for the kind introduction. So I shall straight away start. I hope my screen is visible.
Yes, it is.
So today I shall be speaking about the basic concept of antimicrobial stewardship and how important it is for patient safety. Now, the man who discovered antibiotic for the first time, Sir Alexander Fleming, right in 1945, said soon after his discovery that the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with penicillin-resistant organism. So right in 1940s, he had warned regarding antimicrobial resistance if it is used unjudiciously. And this is data that we presented we published in the journal. This is the high rates of antibiotic resistance found in the bloodstream infections in newborns and children. So this is the largest review of AMR data from India. And we found that there is high level of resistance to the first line antibiotic recommended by World Health Organization for treating sepsis. And then these are just a few headlines I picked up from the newspapers. Just last week, ICMR study reiterating the fact that antimicrobial resistance is on the rise in India. We need urgent corrective measures. Then there was a recent Lancet paper which reported indiscriminate use of azithromycin and ofloxacin. Especially this had happened during COVID. And there is a very scary report that the multi-drug resistant bugs are so high that there is significant death occurring in the hospitals within 14 days of admission. So it is scary, and it is something that each of us must be concerned about, especially with this projection that by 2050, one person could die every 3 seconds. So they have, a model has predicted about 10 million deaths, surpassing the deaths due to cancer even. And what drives the antimicrobial resistance? And for those who do not know much about AMR, you'd be surprised to know it is the use of antibiotics itself, which is the main driving factor for antimicrobial resistance. So how does this happen is that when a population of bacteria is exposed to antibiotics, say the green ones are the ones where they are susceptible to that particular antibiotic, there will be a very small population which might not be killed. And that then later on multiplies. Unfortunately, they not only the resistant bugs multiply, but they also pass on their secret mechanisms of survival to other bacteria. And this goes on and on. So that is how they spread around. And it's not just in human health, but also it has affected the agriculture and food industry, because antibiotics are being used in animals, in poultry, and as well as due to the industrial waste going into the rivers. So we have antibiotics in the soil and the water. So there is scope for passing on the resistant genes all around us. So what do we do to control this rise in antibiotic use? And we need to be as rational in the use as possible by all the stakeholders. And also remember that as by nature, bacteria are known to survive by inventing mechanisms. So there is always a selective pressure. So when you introduce the best antibiotics, still the bacteria might be capable of making a new mechanism to make the antibiotic ineffective. So let me talk a bit about antimicrobial stewardship and how did it evolve. So right in 1960s, this was the first formal assessment of antibiotic use done in Canadian General Hospital, where you can see this figure on your right side. They used a punch card system for electronic coding of certain functions, like what are the drugs, what is the frequency going on, what is the reason for antibiotic use. A lot of functions which probably it's difficult today also to capture. So they did a formal assessment and they found less than 50% are actually used for treatment, whereas the rest of the antibiotics use is actually questionable. And in 1980s, the clinical pharmacy services were set up in United States, and they found errors, especially in the surgical orders. And then in 1996, infection control services were set up. And these two gentlemen, J.E. McGowan Jr. and D.N. Girding, are credited for coining the term antimicrobial stewardship. And it was later, many years later, in 1997, that two major powerful societies of US, the Society for Healthcare Epidemiology of America, that's SHIA, and IDSA, both came together and they defined the antimicrobial stewardship as optimal selection, dose, and duration of treatment, as well as control of antibiotic use. So this will prevent or slow the emergence of resistance. Then in 2007, it made, as well as SHIA, they developed a program for every hospital to enhance this stewardship. And later, it was joined by even the Pediatric Infectious Disease Society in 2012. In 2014 came the very well-known core elements of hospital antibiotic stewardship by the CDC. And in 2017, AMS was made mandatory for accreditation by Joint Commission for all hospitals and nursing care centers in the United States. And this mandatory requirement was extended to outpatient services in 2020. So if you go to see the timeline of evolution of antimicrobial stewardship practices in United States, if you can see that it has evolved gradually, step by step, over half a century from 1970s. And then what happened in India is that there was this huge rise in antimicrobial resistance. India was in global spotlight, especially with NDM reported. So the government had to act fast. It released the national policy for containment of antimicrobial resistance in 2011, followed by treatment guidelines by the ICMR in 2017. And then later came the national guidelines for infection control. So we didn't have the time that probably the Western countries had in developing infrastructure for antibiotic stewardship. And for us, the movement started with the Chennai Declaration 2013, which brought all the societies together to resolve to fight against antimicrobial resistance. And in 2016, a red label was applied over the antibiotics to prevent over-the-counter sale without prescription of without a prescription. So this is a small time frame that we have to face, and that is why, as expected, when ICMR did a surveillance of all the hospitals for readiness for ASP, it found that in many of the hospitals, we have lack of personnel from pharmacology, IT for the AMS program that is followed in the Western countries. And then there are issues of conflicts at professional level. This applies to any place in the world. Now, this is at the level of individual because of poor clinical skills or knowledge or lack of awareness about resistance, or there is lack of confidence. There is peer pressure, which makes one write injudiciously antibiotic. One doctor may fear that the patient may just go to another doctor across the road and get an antibiotic, and that doctor can take credit for the cure. Then there's patient pressure. There are patients saying, no, we have to go out in the weekend. My daughter has an exam. Please write an antibiotic. Or there could be pharma influence. So these factors figure in for injudicious use of antibiotics. Then, of course, there could be lack of leadership support. Fortunately, Apollo has a very strong leadership support. And then interprofessional problems could be there, like senior junior hierarchy. So it is very difficult for a junior to correct a senior if he has written a wrong antibiotic. There could be ego clashes. There could be opposition by the prescribers, like the patient is my responsibility. Who are you to tell me what antibiotic to write? Or there could be poor communication in suggesting the change. So I shall talk a bit about the toolkit, because that's part of the topic also given, antimicrobial stewardship toolkit. And I have been part of this toolkit, which is the official toolkit of Pediatric Infectious Disease Society, as well as the American Academy of Pediatrics. And it follows what the CDC core elements talk about. So let me just explain to you what is done. Is that the first core element is leadership commitment. So unless the leadership is not committed, it is very difficult to run such a program in an institution, because you need resources, you need trained personnel dedicated for this. Then accountability, it is found that if a physician leader is involved, it works better to talk to other physicians. But at the same time, it is not necessary also that it has to be a physician. Sometimes even any person who understands rational use of antibiotics can lead the antimicrobial stewardship team. Then there is drug expertise, which is offered by the pharmacist leader who gives inputs about the correct dosage, drugs, adverse effects, etc. So what is the action that they perform? So this team, the AMS team, which comprises of the physician, pharmacist, or microbiologist, or infection control officer, they go on rounds and they do either a prospective audit and feedback, or they ask for prior approval, especially of the high-end antibiotics, or they look at compliance to the guidelines which are laid down by the international bodies or national bodies, or they check if rapid diagnostic tests have been performed in certain situations. And the questions that they ask in the daily round is, does this patient have an infection that will respond to antibiotics? Have proper cultures and diagnostic tests been performed? Can antibiotics be stopped or improved by narrowing the spectrum, what is called as de-escalation? Or can the antibiotic now be changed from IV to oral? How long should the patient receive antibiotic, considering both the hospital stay and does this patient require any therapy post-discharge? And they also look at three common conditions for which antibiotics are used. So that's urinary tract infection, community-acquired pneumonia, and skin and soft tissue infections. And then what is done is they track data and they measure metrics such as the days of therapy. This is for pediatrics, but in adults, what is done is DDD, that is defined daily dose, length of therapy per 1,000 patient days, standard antibiotic administration rate. This is what CDC uses to compare the administration rate between different hospitals. Then proportion of patients compliant with the guideline or which have been converted to oral therapy, and the acceptance of recommendations. And then, of course, education is done for not only the prescribers, not only doctors, everybody, including the paramedical staff, and whoever are involved in patient care is educated about antibiotic stewardship. Now, in outpatient practice, what is done is there is commitment that should be given by the individual practitioners, and what is checked is that whether guidelines are resorted to, whether the communication can be improved of the clinicians, especially when they don't start antibiotics in viral infections. How about peer accountability? Are they do they give justification if they start high-end antibiotics and for in OPD? And then that is also tracked in terms of proportion of viral infections in outpatient receiving antibiotics, or proportion of the community-acquired infections which receive broad-spectrum antibiotics. And then, of course, education is always a part of any intervention. So WHO brought out this very beautiful document in 2019, which they title as Antimicrobial Stewardship Program in Healthcare Facilities in Low and Middle Income Countries. And this is a very good useful resource, and anyone who's interested in AMS must go through this. The core elements are based on what the CDC also talks about: leadership commitment, accountability, AMS actions, reporting, monitoring, and education. And what they recommend is to do a SWOT analysis. If you want to start ASP in the institution, first find out what is the strength. S stands for strength, W for weakness in the institution. Are there any opportunities, and are there any threats to implementing such a program? Now, what is recommended is once you prepare yourself to implement the program, then you make SMART goals. SMART goals means the goal should be specific, measurable, attainable, relevant, and time-bound. For example, if you want to bring down the consumption of high-end antibiotics such as carbapenem, say it is 40% right now, you want to bring it to 20%. So these are measurable, and you should give a time bound. You want to bring it down in a year's time, in 2 years' time. So that is why the goal should fall into this SMART category. You should define what you want to do and in what time you want to do. And you should pick up something that is attainable and relevant. And then according to the goal, you can, what you do is basically, say you want to bring down the consumption, you may educate the prescribers or plan some awareness program, etc. And then you have to track what is happening. You study if the intervention has been successful. If not, then you can improve further. So this is a continuous process of plan, do, study, adjust, plan, do, study, adjust. So, how to improve antibiotic use? Antibiotic use can be improved by not using antimicrobial when not indicated, using it when indicated. That's also extremely important, because in certain situations you have to act fast because antibiotics are also life saving. And when using antimicrobial, use it in the 5 correct Ds: the right drug, right dose interval, right duration, and right delivery. Delivery, I mean whether rightly oral or parenteral route. And the 5 golden questions for starting any antibiotic empirically. Empirically means we have not confirmed what infection, but you think there is a bacterial infection. So the first question: what is the likely organism? Is it a viral you're thinking of? Then why write an antibiotic? Is it a bacterial? Then is it a gram positive, gram negative? Because certain antibiotics have different actions. Where is the site of infection? Will your antibiotic reach that site? If it is in the brain, will it cross the blood-brain barrier? Is there a host comorbidity? Is the patient having some renal problem where you can't use this antibiotic? How is the severity of illness? Do you want to start it immediately? Can you wait? Should you use an IV route immediately? Or is there a high risk for resistance? I mean, is it like you're suspecting a multi-drug resistant upfront because of some contact history with another patient or so? So I understand that the crowd all are not, may not be prescribers, but this is just very roughly I can give you an idea based on a child, 4-year-old, who has fever, cough, cold since 2 days. He's active, jumping around, playing around, the chest is clear. So the doctor rightly would suspect that this is a viral infection. So once you have the answer that this is most likely a viral infection, we can wait, counsel the patient, and rest of the questions are not applicable. But if you have a child who is having sight sound, you have a wheezing sound, but still the child is very active, playful, maybe still a viral infection, most likely, because you can wait. So right now you don't write an antibiotic, but there are situations where the child is not so active. You have a clinical clue of a bacterial infection, and then you start an antibiotic, you write an indication, and you write the right antibiotic, which is recommended by the standard guidelines. And the right, then you check whether it's the right dose interval, and the duration, and the delivery. And there could be situations where the same patient might require an inpatient care. Again, the same thing, you need to check the doses. And when the child is fit for an oral switch, then you switch to the correct antibiotic in the correct dosage again. And suppose there is a child who comes in the ER with pulses not recordable, it's in shock, very sick, with then it becomes a medical emergency. But still, you can still send the blood culture and immediately push in the high-end antibiotics. But whatever high-end antibiotics you start, considering the clinical situation, when the culture comes back, you need to modify. That is important. Modify as per the culture report. And if it is showing something, say in this case, it is showing a bug which needs a lower antibiotic, and you may have to just knock off 1 or 2 antibiotics. So that is what is necessary in our day-to-day practice. Now, let us look at, again, the document. This is from WHO document. So they talk about looking at the indication and prescribing the correct antibiotic, reviewing it. You need to review once you have written an antibiotic, whether it's really the right decision, whether you want to change to oral and have the microbiological results come, and when you want to stop it. And especially for surgical prophylaxis, you need to make sure the antibiotic goes in time within 1 hour of incision, ideally half an hour of incision in the OT. and it should be stopped. After all, it's prophylaxis, means prevention and not treatment. So it is usually, in majority of the surgeries, antibiotics need to be stopped after 24 hours of surgery. So Lord Kevin happened to give this famous quote: if you can't measure it, you can't improve it. So whatever intervention is done in the hospital has to be measured. And the WHO recommends 3 types of measure for stewardship. Structure measures, what they mean is the metrics that I talked of: defined daily dose, DOTS, proportion of aware in DDS. Means these are basically the antibiotic consumption, what is happening, whether the high-end antibiotics are used more in proportion. Aware is a recent classification of antibiotics by the World Health Organization, where they have classified antibiotics into access, watch, and reserve group. So access is the antibiotics which have least chances of becoming resistant, and we are supposed to use more from antibiotics from this group and restrict ourselves from antibiotics from the reserve group. Then process measures are patient outcomes and microbiological outcomes. Patient outcomes can be in terms of mortality, length of hospital stay, whether readmission is required, and microbiological outcomes are whether multi-drug resistant organisms rate can be identified, Clostridium difficile rate. And outcome means documented indication for antibiotic use is there or not. How much is the compliance to standard treatment guidelines? What is the compliance to the surgical prophylaxis, etc. And then there are various educational tools one can go through. You go through textbooks, journals about antimicrobial stewardship. What is the recommendation? There are so many modules, workshops, conferences, webinars such as these, and there are electronic sources, ample of them, about the correct treatment and recommendation and what is antimicrobial stewardship. And there are specific courses for those who are interested. These are free courses, very good courses developed by the World Health Organization. If you are interested, you can do these courses. And what we have found is that among the patients, the common man, they are not so aware about antibiotics. In fact, when we did a survey of around 872 parents, we found only 1/4 of them actually could identify that antibiotics are used against bacterial infections only, and not against viral infections. And still lesser, only 15% parents actually knew the term antibiotic resistance. So that means the awareness about antibiotic use is very low in our community. Then how could you tackle that? We need to educate our patients. There are very beautiful handouts that have been made by the CDC, and you will have many, even Indian style with Indian characters, that antibiotics do not work on colds or most coughs and sore throats. So these can be handed out to patients. So patient awareness and education is an important tool. I've been fortunately part of the policy statement of American Academy of Pediatrics for antibiotic stewardship in pediatrics. For those who are interested, can go through this. So my final slides message for prescribers is that set small targets in practice. Do not using antibiotics for a very evident viral infection such as watery diarrhea or watery nose to start with. Document and self-audit. So it is important to think before you ink, whether you really require to write an antibiotic. And you can use smartphones. Nowadays, there is access of ample information about the dosage, drugs, what is recommended for that particular condition. And then you can go by what is recommended by national and international bodies. And there is revolution of molecular tests, point of care tests, rapid malarial antigen, dengue tests, which tell you immediately that no, this is dengue, this is COVID, you don't have to start antibiotics, this is viral infection. And of course, you need to send appropriate cultures in bacterial infections. My colleague, Dr. Narendra Patil, will tell you about this, that you need to do this and modify based on cultures. Seek second opinion for person experienced with infectious disease for complicated situations. Do not hesitate to take help And this is for all, whether it is infection control, whether it's for pharmacy or for any situation. Please seek expert opinion, and also train your colleagues, juniors, and paramedical staff regarding rational use of antibiotics and infection control. This can be done by any paramedical person or a doctor, that you need to train your colleagues too about antibiotic use. So every healthcare worker has a crucial individual role in ASP. So ASP is a complete teamwork. It is not just that doctors should be involved only or microbiologists are involved. It is an entire teamwork. Only then it will succeed. And play the role model of antibiotic champion in the community. So please spread the awareness. And so only if we all work together can we achieve antimicrobial stewardship, which is so important for the outcome, good outcome of the patient and for our future generation. Thank you. Just to talk about that, this year, the World Health Organization, it brings out a theme every year. Last year, it was handle antimicrobials with care. But today, recognizing that antibiotic misuse is happening in many fields, it is the theme this year is preventing antimicrobial resistance together, where even the Food and Agriculture and Veterinary Department of World Health Organization has come together along with human health, and all should come together and act. Thank you.
Thank you, Dr. Dhanya, for a very thoughtful and interesting presentation and discussion. Let us move to the next part of our today's session. Before that, let me introduce you to our next speaker, Dr. Narendra Patil. Dr. Patil is MD in microbiology with more than 10 years of experience in clinical microbiology and infection control. Currently, he is working with Apollo Hospitals, Navi Mumbai. He has numerous national and international publications to his credit. His special areas of interest include implementation of cost-effective, evidence-based infection control programs. He has a hands-on experience in laying the foundation of the AMS program in one of the IDSA Center of Excellence for Antimicrobial Stewardship in India. So, Dr. Patil, I have a set of questions for you, and we start our discussion. So my first question to you is, how do we make the AMS program implementation happen in a hospital or a healthcare organization?
Yeah, so very good afternoon to everyone. Dr. Dhanya has already briefed about like how the program is to be formulated and what are the standard guidelines and what are the resources available online, as well as in the various websites, applications, or organizations. So hospitals don't look like the same. All hospitals don't look like the same. So the antimicrobial stewardship program is not same for every hospital. It has to be flexible and made tailored as per the organization needs and the organization commitments. So there must be flexibility for how this program needs to be implemented. And there are some elements which Dr. Dhanya also highlighted, core elements of antimicrobial stewardship, which needs to be looked into, and they are the key to success. So just to name a few, like leadership commitment. Unless and until there is a leadership commitment in any organization, implementing antimicrobial stewardship becomes a challenge. Fortunately, as Dr. Dhanya has also said, in AHNM or as well as Apollo Group, we have a good support from leadership. That is why we will be able to implement these programs. Making single leader responsible for the entire program, that is the need of an hour, because if we look at the committee based or the group based approach, it becomes difficult to track and follow the activities. So making a single leader responsible is always important if you really want to implement antimicrobial stewardship program, whether it's a small organization or a big organization. Single pharmacy leader and antimicrobial use tracking. So pharmacy plays an important role in this for governing the antimicrobial use. as well as various parameters Dr. Dhanya has mentioned, like days of therapy per 1000 IP days, or DDD, defined daily dose. So these can be tracked, and unless, as her slide, one of the slide was, unless we measure, we cannot implement. So we can have a track of these antimicrobial usage, whether we are going on higher side, lower side, and accordingly we can plan our actions based on this. Educating the care providers, of course, one of the key element in this, right from the beginning, in the inception of the institution, or right from the lowest category of the staff to the highest. So that should cover all the stratas of the hospital employees, so that it's a responsibility of everyone, not only the doctors or the nurse or the pharmacist. Antimicrobial stewardship, or the rational use of antimicrobial, is responsibility of patient as well. So education of patient also becomes an important part, or important aspect of this.
Right. Thank you. And what do you think would be the main challenges while we are implementing the AMS?
So major challenges, I would say, is a few of the challenges Dr. Dhanya has also mentioned in one of the slides, like conflicts, as well as a fear of antimicrobial resistance, and bad clinical outcomes that most of the times encourages or provokes the people to use higher end antibiotics in the early phase of the infection itself. And acceptance become a major challenge. Dr. Dhanya, can you contribute if there is any other thing?
Yeah, so the main issue that we have realized is the fear of losing the patient, in the sense to some other doctor who might write an antibiotic, and there is always a fear that, okay, today I don't write an antibiotic, and then the patient develops some complication. Will the patient blame me for it? So an insecurity is a problem. So what we have realized is having a group practice is a good idea. When you have a group practice in the hospitals, if the patient care is improved, you can discuss amongst yourself, and it gives more security. The other thing is that if basically the counseling of the patient is that communication is extremely important. So in this hurdle, suppose one patient is detected to be probably a viral infection, and the doctor does not write an antibiotic. The doctor has to communicate to the patient what is to be done for the fever, cough, and why he's not writing an antibiotic if the patient asks. So that counseling, communication, a good communication will also put the patient at ease. There are other hurdles which are not specific to Apollo, but there are problems about not enough diagnostics available elsewhere, especially in districts. The blood cultures and all become very expensive. So then antibiotics are resorted to because of lack of diagnostic support. Multiple antibiotics are written for malaria, for bacterial infection together. So that is something that we need to look at, maybe through the industry, to the government, to increase the diagnostic support to the clinicians. And of course, the public awareness as it goes up. If you let me just tell you an example. In US, the public awareness of even antibiotic use in the poultry could drive the big giants like McDonald's advertising or KFC advertising that they do not use antibiotics in their poultry. So public awareness, once it goes up, we have seen it in COVID also, wearing masks. Unless the public is not aware, it becomes difficult to have any kind of a public health intervention. So that is important. So these hurdles, if they are overcome, the individual physicians are given support in terms of diagnostics as well as the patient education, of course, things would be better.
Yeah.
So my next question would be to Dr. Dhanya. What are the safety considerations for using antimicrobials in special population like children, pregnant women, elderly population, and those having allergies?
Okay. So children are a special, they are special, aren't they? And not just because I'm a pediatrician, but the antibiotics are actually calculated by weight in children as opposed to the adults. So one has to check the weight of the child because it can be easily underdosed or overdosed. And for the pregnant ladies, there are some antibiotics which can cause teratogenic effects on the fetus. So there are certain antibiotics which are completely no to pregnant ladies. So one has to be careful. There may be patients with allergies. So if one has had past history of anaphylaxis to certain antibiotics, so one has to be careful not to have repeat incidents. And so allergy check is something that needs to be done before writing an antibiotic. And then there are certain conditions where some antibiotics cannot be given. Like, for example, there's a condition called G6PD deficiency in the blood, where certain antibiotics such as primaquine, nitrofurantoin, they cannot be given. It can cause adverse effects. And of course, those who have kidney problems, there are certain antibiotics which could make drive them to further kidney compromise, such as aminoglycosides, vancomycin, etc. So one has to be careful. So basically, the it is not just about giving antibiotic. It is also knowing the patient. Which kind of patient are you treating? Does the patient have any problem that can cause further adverse events if that antibiotic is given? So that is a crucial part of patient safety.
Great. So would you also like to comment, Dr. Patil and yourself, Dr. Dhanya, that how are we using technology to help improve the implementation of AMS in our hospitals?
So if we go about it, like the major part, as we discussed, antimicrobial consumption, that gives a fair idea about like which antibiotic is being used in what proportion, as well as comparing with our IP days and indications. So interventions as compared to conventional methods, we have a automated extracted data which comes from a pharmacy end, so that we can get to know like which patients were prescribed which antibiotic, and we can collate this at the end of the month, so that automatically we get to know how much antibiotic is prescribed. That makes a life quite easy as compared to the conventional method, which is like we have to go through papers and then document each and every day antibiotics, as well as use of Microsoft Forms for the data collection. So nowadays, because of smartphones, we have used we have been using certain forms, like hand hygiene has been automated, as well as our daily antimicrobial stewardship round. So that can also be automated with the help of and these Microsoft Forms. Surgical prophylaxis. So at the end of the month, you get a real-time data, or in between also, if you really want to analyze the data at the end of 15 days or 7 days, we can take out the data and analyze in real time. So that gives a fair idea like how we are performing. So these are some advantages of using these IT initiatives in the hospital, and we have been successfully using in our hospital. Anything else from your?
Yeah, I totally agree that IT has revolutionized AMS, and it's easy to now electronically retrieve a lot of data, whether what antibiotics have been consumed, and the electronic records can be retrieved even few years later. So that is very helpful. Secondly, also in the microbiological part, just an example of tuberculosis. The sputum is given, and we know within 2 hours whether it is drug resistant or drug sensitive tuberculosis, and antibiotics can be started correctly accordingly. So molecular technology has revolutionized, has been a game changer both in the diagnosis and of course the IT support in kind of interventions. Unfortunately, the IT support is only available in certain bigger hospitals, and it may not be available in most of the hospitals other than, I'm talking out of Apollo network, do not have this IT support so much. So then it becomes difficult to retrieve through paper work. Going through files become a very tedious task. Also, we do not know what antibiotics are sold in the chemist shops. because there are no electronic records. I mean, it's very difficult to find out. If today someone is to find out how many grams of a particular high-end antibiotic has been sold in the city, it's very difficult to find out unless they look at the purchase, sale, etc. But very difficult to find out how much has been dispensed since we don't have electronic records for all the pharmacy shops in the country. So there are several hurdles, but IT is a way forward. Yes.
So that's very informative, ma'am. Now, since we have a lot of, the quality and the patient safety teams attending this session, so we would all like to know what is the role of quality and the patient safety teams for the successful implementation of the AMS program in our hospitals, and what all are we supposed to do?
If we look at it from the quality perspective, improving the antimicrobial prescription practices itself will ultimately help into better patient outcomes and prevention of multi-drug resistant infection, as well as transmission of these infections and overuse of antibiotics. So in long run, definitely it will help us to have a better flora and better susceptibility profile among the patients getting admitted into our hospital. As far as the initiative from the quality teams is concerned, so the quality indicators which we are monitoring, or overall also in the accreditation process, as Dr. Dhanya has mentioned, in 2017 JCI has made it mandatory to have antimicrobial stewardship under MMU, and in 2020 it has extended to outpatient department. So a quality team can help us to can intervene to analyze this and keep a check on outcomes, as well as the day-to-day functions of antimicrobial stewardship team.
Right, and the quality team representative is always part of the antimicrobial stewardship committee of the institution. Also, the quality head is part of the National Advisory Committee of Antimicrobial Stewardship. So they are valuable inputs for monitoring the entire process, liaising with the different departments, and of course, looking at the metrics, auditing, all that is extremely important for this program.
Right. So what are the different resources if one needs to get guidance or tools for on-ground implementation of the AMS program? What would you suggest, apart from a lot of resources that we have which are available on the net? Are there any specific tools that you would like to suggest?
So if we look at CDC website, so they have a ready Excel template also if we need to monitor the antibiotic use. So that can be directly utilized. We can feed the data and we get the outcomes. So that is one tool which can be downloaded from CDC website of antimicrobial stewardship. Apart from that, WHO has a very elaborative web page on calculation of defined daily dose. So they have even coded this antibiotic, which code has to be used for which antibiotic, and how to calculate and how to go about the defined daily dose calculation for that particular antibiotic. So that is one more resource which can be effectively used. As well as Dr. Dhanya's slides also has a few interesting guidelines, like PEDS has also released, as well as a policy document by USA Pediatric Infectious Disease Society. So that is also an important resource from where one can take guidance and implement a program in their institute. Anything else from you, Dhanya?
And also the WHO has one or two very good courses on antimicrobial resistance, as well as ASP, which is free. They don't charge anything. And it's like you can complete it as per your convenience and get a certificate. So these courses are also interesting. And there will be, I mean, if you need to be on a lookout, there'll be definitely some courses available in India by certain hospitals on AMSP, and conferences are a good way. If there are certain speakers who are involved in ASP, interact with them. So those who are interested can just, nowadays it's so easy to just Google and find out what courses are available.
Okay. Also would like to know, how does the patient education have a role for the successful implementation of the AMS program?
Yeah, so this has already been actually answered. So
Yeah.
patient education is extremely important, because unless the patient understands why about antimicrobial resistance, they are. It's not just about giving them antibiotics, right? They are the ones who are going to use those antibiotics. So sometimes a patient refer to previous prescription and use that antibiotic. Sometimes they just go over the counter and take the antibiotic. Then they resort to self medication. Sometimes they don't complete the antibiotic course. Maybe in 1 to 2 days the child gets better, okay, the parent feels, why give the complete course? They may give half the dose if the child develops diarrhea. So basically, actually the patient education is extremely critical, because they are the ones who are giving the antibiotics. Ultimately, whatever you prescribe, you may prescribe the best antibiotic, best rationally, the dose, everything can be right, but ultimately that antibiotic will be taken by the patient. So the patient education is of course crucial.
Okay, so we have some audience questions. This question from Dr. Yerle. He's asking, do you think a workshop on implementation of AMSP, wherein the core team member from all the group institutions will help to brainstorm and get it on track?
Yeah, certainly. That's a great idea. If there can be, when we share experiences with each other, with people who are involved with ASP, we can, of course, take the positive points and improve our own programs. So,
Okay.
I think, yes, Dr. Narendra, you want to?
No, and that's perfectly fine. So once we have a group workshop, it will definitely help us to come out with better ideas and on track.
And what are we going to do, to get clinical pharmacists with AMS training or background on board?
Yes, so this is just to announce, but this is specific to Apollo Hospitals, that we are launching the National Antibiotic Stewardship Program next month. So we have already made training modules for all the clinical pharmacists and the nurses who are going to be the backbone for this program. So just so that they also become very confident about the antibiotic use, when to de-escalate, escalate, and appropriateness, etc. But clinical pharmacists somehow, as compared to the Western countries, have not been given the recognition they deserve in our country. And there are so many government hospitals which do not even have the official post for clinical pharmacists. Clinical pharmacist is an unexplored. They are basically this field needs to come up, and this field needs to be encouraged by everybody. So they are very helpful for antibiotic stewardship.
So as we are concluding, I would like to thank our esteemed speakers once again for sharing their knowledge, their expertise, and their time with us. And I would also like to thank the audience for being there with us. And before we close, I have an important announcement to make. Ma'am, could you please share the slides, the last two slides? Yes. So please, to the audience, we have a request. Please stay tuned for the upcoming knowledge series of our the Apollo patient safety webinars till the 17th of September. Please tune into tomorrow's webinar session, and the topic is medication supply chain excellence, opportunities and challenges. And this is a panel discussion and very informative for all those who want to understand supply chain management and medication. All participants who are attending our webinar series for the 6 days have a very good chance to win a lucky draws. We are soon going to get in touch with the winners shortly. All participants of the webinars will get digital certificates through our team. And I would also like to request our audience to please enroll for the Patient Safety Club, which has been instituted by the Apollo Hospitals Group. The aim of the Patient Safety Club is to share knowledge and again, it's a knowledge sharing platform amongst the patient safety experts, and we are all here to gain and learn from each other. And the last announcement I want to make is about the 9th International Patient Safety Conference. The Patient Safety Conference, the biggest patient safety conference, which is supposed to be held in India, and it is planned for the 1st and 2nd February 2023. It will be held in New Delhi. The pre-registrations are open for this conference. Please, please check the details on the Apollo International Patient Safety Conference website, or you can write to us for detailed any queries that you have. And we are requesting you to get early bird registrations done for the conference, as it includes discounted conference fees and other exciting features. So thanking you once again for joining us in this session, and hope to see you soon again. Thank you.
Thank you. Thank you. Thank you.
Thank you so much, Ankit. Thank you.